Yeah, good afternoon, everyone. Welcome to this webinar on the role of ultrasound in evaluation of upper limb nerve entrapment syndromes. Basically, goes to say that how we can use ultrasound as a tool, how it helps us in management of these painful chronic pain entrapment conditions. I'm Dr. Prashanth R, consultant interventional pain physician at Elevate Pain Clinics, Bangalore. So the entire webinar will be based on this overview of each topic being discussed under anatomy, sonoanatomy, clinical features, and the ultrasound findings of these conditions pertaining to the specific nerve entrapment syndromes. Okay. So nerve compression syndromes commonly involve the nerves in the upper extremity. So compared to the lower extremity, it's more common in the upper extremity. And high resolution ultrasonography can satisfactorily assess these nerves and may detect the morphological changes of the nerves. So it's not only the changes in the nerves, we will see that there will be changes involved in the muscles and also in the nerves. Okay. So coming to the brief anatomy, since we are dealing with the nerves of the upper limb, so rightly so that these are coming from the roots C5 to T1. After that, we have the trunks, further down into divisions, cords, and the branches. So the branches we are mainly interested will be the median nerve, the alar nerve, and the radial nerve. So in terms of the vascularity, how these cords are named is based on the location around the brachial artery. So we have the medial cord, the posterior cord, and the lateral cord, from which we have the further branches we just spoke about. So it is very important to know about the normal sonographic appearance of the structures which we are going to be dealing with today. That is, more of interest will be the nerve, the tendon, and the muscle. Okay. So on the right hand side, you have this picture wherein you can see a nice hyperechoic structure which has hypoechoic structures in between, surrounded by hyperechoic structures. So this is the normal fascicular pattern of the nerves which are seen distally. So distally in the sense from the center, from the axial center, as we move on to the periphery, the fascicular nature of the nerves is seen better because there is more of connective tissue within this peripheral nerves. So that gives them this nice hyperechoic fascicular pattern. Okay. So on this, on the right hand side now, we have the another structure. The sonographic nature of this will be mainly a hypoechoic structure with hyperechoic lines, striated lines within them. So this is a very classical appearance of a muscle. Okay. So exactly the structure beneath this, if you ask me, it looks like a tendon, but it's not a tendon. It is a long axis of one of the muscles, that is the pectoralis minor muscle. So this is the confusion. So what it says is the normal sonographic appearance of these structures has to be learned first. Okay. So you can view the muscle on the long axis or on the short axis. Similarly, you can view the nerve under the, this is the short axis of that, and you can, if you toggle the probe, we'll be getting the long axis. So now, what kind of probe are we using? Okay. So the probe required for the evaluation of nerves of the upper limb would be a linear probe because these structures are very much superficial. All right. So, and they would require a probe which has lesser penetration but high resolution, which is again sufficed by the linear probe, high resolution, high frequency linear probe, as you can see here. Okay. So now this is a very important point I wanted to highlight, that is about anisotropy, because everything we talk about today and ultrasonographic evaluation depends on this, because it is a user dependent uh, kind of evaluation. So the user has to be very aware of these kind of artifacts which they can encounter while evaluating these nerves or muscles or tendons. Okay, so one of the most important confusing aspect will be anisotropy. So to make it clear, you can see the two pictures over here. So we have what appears to be a nice fascicular pattern of a nerve, okay, displayed in both the images, whereas here you are not able to view the clear-cut image. So now you would think that okay, there is some damage to the nerve or it can lead to misdiagnosis. This is mainly because of the angle of incidence. So the angle of incidence between the ultrasound beam and the nerve is important for optimal imaging. So in this picture, in this particular picture on the left hand side, you can see that the structure we are interested over here is running like this horizontally, and the probe is exactly perpendicularly placed onto that structure. So, excuse me. So this is a structure of interest. This is a probe which is placed on the skin surface, exactly perpendicular to the axis of the structure, so that the incident beams and the reflected beams are all are equally received by the probe. Okay, so if you tilt as it is seen in this picture, what happens is the echoes which are coming back from the point of interest is actually not being captured by the probe. So it leads to a false sense of evaluation of that particular structure. So this particular toggling and remembering the PART, that is the pressure, angulation, alignment, rotation, tilting of ultrasound and the ergonomics should be maintained before we jump into evaluation and also before making any diagnosis of the particular situation or the structure. Okay, so moving on to the first nerve of evaluation, that will be the median nerve. So once it you know that the median nerve in the arm is mainly in the medial side, it is accompanied by the brachial artery. So and as it reaches the elbow, so what happens is it moves on to the anterior aspect. Okay, so this is the model of the elbow. So once it is on the medial aspect of the arm over here, it moves on to the anterior aspect at the elbow. So here you can see there are different cross sections of that at different levels. What happens? So the main muscle which you're interested here will be the pronator teres muscle, because it passes through the two heads of the pronator teres muscle, that is the humeral head and the ulnar head. Okay, so until then it is placed, you can see in the cross section B over here, which is corresponding this particular ultrasound view, where if it is in the anterior aspect of the elbow, it is accompanied by the brachial artery and the brachial vein. Okay, the nice multi-fascicular nature of the median nerve is seen. So as we move distally, we have to scan. As we scan distally, we will reach a point where the brachial artery is dividing into the radial artery and the ulnar artery. That is where again the nerve divides. The nerve also divides into its branches. Okay, and that is where it gives off the anterior interosseous nerve and then the deep nerve, the sensory and the motor part. Okay, so as it is, this is the picture where that is happening at the distal end, at the proximal end of the pronator teres muscle. This you can see the two heads, the ulnar head and the humeral head, and it is actually dividing over there. Okay, and then further it is in association with the flexor pollicis longus and the flexor digitorum profundus muscle, where the sensor, when the main median nerve in the arm is very superficially placed and moves up to the wrist. Okay, so we do know that this nerve can get entrapped at many places. Okay, one of the common places will be between the muscle. Okay, that is at the level of the pronator teres muscle. Okay, and it can involve the one of the branches of the median nerve. Okay, so let's see what those are. So one of the syndromes is the pronator teres syndrome, wherein the median nerve compression occurs at the elbow between the two heads of the pronator teres muscle. Okay, so now the symptoms. Coming to the symptoms, they're very similar to the cubital tunnel, the carpal tunnel syndrome. The hand symptoms are very similar to the carpal tunnel syndrome, whereas at the arm level, they can be numbness and hypoesthesia at the volar aspect of the arm. Okay, so the causes would be definitely, you can see as it passes, it could be involving the any of the tendons of those muscles, any hypertrophy of those tendons, and a very common involvement because they're always accompanied by a vessel, any hematoma, any neuroma, any trauma. Okay, all these are very common features, but here specifically it involves the pronator teres muscle. Okay, so what are the features of this pronator teres syndrome? Ultrasound. So basically, you can see, you can evaluate the nerve. So when you evaluate the nerve, first and foremost, the normal echogenic appearance has to be understood. You can always compare. Okay, with the normal side, you can compare. You have to look for the features of the muscle also involved. Okay, so the what is stated is that they can be increase in the size of the nerve, or it can be involving the muscles. So how the muscles appear? The muscles are usually denervated, right? So especially in this, the anterior interosseous nerve syndrome. Okay, so how do the patients present with? They present with motor disturbance because this is a more main motor nerve which supplies a lot of muscles over there. The radial side of the FDP, the FPL, and then we have the pronator quadratus also being supplied. Okay, and then mainly involving the intrinsic muscles and the thenar muscles. So when you evaluate, it's a classic sign called a circle sign, wherein the patient will not be able to make an O with the help of the thumb and index finger and the middle fingers. Okay, because of the loss of denervation. Okay, so again, causes can be the similar causes like the hematoma, the neuromas, or any fractures, post-surgical involvement, right? So what happens here is you can see that the nerve is closely in relation with the FPL and the radial side of the FTP, and further moving on to the pronator quadratus. So what I want you to focus here is, see, even this is the FDS muscle. Okay, see the echogenicity of this muscle and the pronator quadratus. So they can become hyperechoic. The denervated muscles can become hyperechoic. So ultrasound, if you have, if you scrutinize, you have to look for these symptoms, these signs as well, not only for the nerve. So the problem with the evaluation of the anterior interosseous nerve is its nerve is very small. Okay, so it is hard. Most of the time we'll not be able to see visualize the echogenicity of the nerve per se. So we look for these indirect signs. Along with definitely the clinical evaluation is a must. This is just a talk to tell you how you can ultrasound also can pick up subtle signs in these particular scenarios. So again, this is evaluated with the MRI. So coming to the most common entrapment syndrome, that is the carpal tunnel syndrome. So we know that this involves the median nerve. Okay, so specifically at the carpal tunnel. Okay, so the carpal tunnel again, grossly we have the proximal crease and the distal crease. If you talk about the bones, we are more mainly what do you say? We are more looking into the scaphoid and the hamate and the trapezium as well at the distal aspect with the hook of the hamate at the distal aspect of the carpal tunnel. So causes could be, so you know that there are a lot of tendons, the FDP, the flexor digitorum profundus. Okay, so tenosynovitis of all those, any of those flexor tendons. So mind you, this tenosynovitis of flexor tendons can be one of the causes for the recurrence of this particular carpal tunnel syndrome after you have been treated it. Okay. So then there can be space occupying lesions such as ganglions or tumors, nerve swelling, which is again related to the thyroid disease or pregnancy, amyloid deposition, post-traumatic fibrosis, excess fat, and then the anatomic variations like the persistent median artery or the bifid median nerve, with or without the bifid median nerve, and any other anomalous muscle. Okay. So ultrasound has been used for patients with CTS as an additional diagnostic tool since it's a big nerve. The median nerve is quite a big nerve in the evaluation. So you can see the morphological changes and the size abnormalities of the median nerve, which can demonstrate the compression. So one thing to be kept in mind is you have to visualize the nerve both in the short axis and the long axis. And in the long axis, you can appreciate if there is a compression, there's a proximal increase in size of the nerve. Okay, all these features can be seen. Overall, in the short axis, so this is the short axis of the median nerve, a fasciculated nature of the median nerve, but there is definitely edema. There is edema, there is hypertrophy of the median nerve. Okay, this could be because of any of those depositions, like amyloid deposition, which we just spoke about. So you can see that you can toggle the evaluation, the assessment tools on ultrasound, and you can actually measure the size. So this is again confirmed with the help of MRI. Okay. So one of the causes I was already mentioned, the bifid median nerve. So you can see nicely appreciate the two fascicles over here. Okay. So before going to the evaluation per se, the normal sonogram at the carpal tunnel. So you have the bony boundaries, the scaphoid, and the pisiform. Okay, then the flexor retinaculum, and then you have these tendons of FDS, FTP, and then the median nerve nicely placed on top. Okay, over here, the fascicular nature. But there can be confusion at this level because many of these tendons also appear fascicular in nature. So how to sort this out? So once you start scanning at this level, at the say the distal level, follow the target of interest proximity. Okay. So whichever is not the nerve, that is a tendon, will eventually become the muscle. So you can trace it into the muscle belly, whereas the nerve will remain as a nerve. Okay, so it will still be the fascicular nature can be appreciated. All right. So this is at the proximal carpal tunnel. This is the distal tunnel where the bony boundaries will be the trapezium and the hook of the hamate, and the arrow marks are nothing but the flexor retinaculum. Okay. So again, short axis view. So we know that the clinical signs, tingling, numbness, okay, involving the thumb, the index, and the middle fingers. There could be motor weakness in case of carpal tunnel syndrome. And then further, you just put on the, you just place your probe on the vital tunnel, and then you can evaluate the size of the median. Okay. So here this is the eclipse evaluation. Okay. Sorry. Yeah, the eclipse evaluation, ellipsoidal evaluation. Sorry, the evaluation of the nerve, wherein you can see the circumference, right? So the cutoff value between 9 millimeter square and 10 millimeter square at the scaphoid pisiform level is suggested as a diagnostic criteria for CTS with acceptable sensitivity and specificity. Okay, anything more than that, definitely you can think of CTS, right? So again, you can see it's quite enlarged over here. And then when you toggle onto the long axis, you can see that there is a fusiform swelling distally over here to the compression. You can see that there's a swelling of the nerve. So as I said, this is one of the recurrent causes of carpal tunnel syndrome, because per se that there is no involvement of the nerve here, because it's because of the compression, because of the space occupying part due to the tenosynovitis of the flexor tendons. Okay, so this has to be borne in mind, and can be seen in various conditions which cause chronic pain and arthritis as well. So due evaluation has to be done other than the ultrasound evaluation with the blood investigations. Moving on to the ulnar nerve. So we know that the ulnar nerve is associated with the cubital tunnel. Okay, so the cubital tunnel again, it's a main bony landmark is the medial epicondyle, and then you have the olecranon on the lateral aspect. Then you have the other boundaries of the cubital tunnel as well. I'll come to that. So here we are seeing the nerve as it enters the cubital tunnel. Then again between the two heads of the flexor carpi ulnaris, it just moves anteriorly to the anterior aspect of the elbow, and then further it will be associated with the ulnar artery all the way up to the Guyon's canal. Okay, another canal which it encounters at the wrist in the Guyon's canal, and then there it divides into this the sensory branches, and it can get entrapped at this level or even at the Guyon canal level. So this is the cross section marked as B. So you have the medial epicondyle, and then that's called the dirty appearance of the ulnar nerve. Okay, so injections around here have to be very careful because it's an enclosed space and it can cause further compression, right? So it has to be very carefully done. So what are the causes of this cubital tunnel? Before that, what are the boundaries formed by the olecranon process laterally, posterior cortex of the medial epicondyle medially, elbow joint capsule and posterior bundle of medial collateral ligament anteriorly, cubital tunnel reticularicum, also called as osborne ligament, posteriorly. So it's like a a rectangular kind of a space. So the syndrome can be because of bony fragments, loose bodies, or the spur arising from the elbow joints, space occupying lesions such as tumors, ganglia, hematomas are common conditions for any of the nerve entrapments. Synovitis from the elbow joint, ligamentous inflammation, accessory muscles, dislocation of the nerve, post-surgical scar. One important thing before evaluating an ultrasound would be you have to keep the elbow extended, not in a flex position. Okay, because in the flex position the nerve can get dislocated. Okay, so you have to keep it extended and then evaluate the nerve. So features of the cubital tunnel syndrome would be medial elbow pain, numbness in the ring and the little fingers. You know that with the middle aspects of the ring and the little fingers, weakness in the intrinsic hand muscles, may show a claw hand deformity due to volume loss in the first interosseous space and hypothenar eminence, and semiflexion deformity involving the ring and the little fingers. So here you can see an X-ray of the elbow with all these osteophytes, arthritis, loose bodies, which can definitely cause compression of the. This is the medial epicondyle, so compression of the ulnar nerve over here. And then again, you evaluate and see that there is enlargement of the nerve. Okay, so this can be involved in post-surgical scars also, because we had a case wherein they had done a surgery for nerve entrapment and nerve release, but unfortunately the nerve got entrapped in the scar of that particular surgery. So the patient was having persistent pain and wasn't even able to wear her bangles. Okay, so that much of hyperesthesia, allodynia, features in the volar aspect and the volar medial aspect, and then with multiple therapy, perineural prolog therapy sessions, she has been doing quite well now. Okay, so what about the cutoff value? Again, 10 mm square is of 88% sensitive and specific for the diagnosis of cubital tunnel syndrome. Okay, so yeah, that's about that. Then the Guyon canal. So as I told you, again, distally at the level of the pisiform, it can get entrapped over there, which is in the Guyon's canal, which is an oblique fibrosis tunnel with length about 4 centimeters between the hook of the hamate and the pisiform. It's also called a cyclist palsy, and it can be involved in people who are actively using their wrist, right? Like carpenter, hammering, or any of the occupational where it requires a lot of repetitive movement of the wrist. So you can see that nicely appreciate the pisiform bone, and then you can see the ulnar artery with the ulnar nerve. The vascular nature of the nerve can be nicely seen. And then at the level of when you go a little distally, you can see it divides over here, nerve divides, and then it's easy to evaluate at this level. You can see that in case of the syndrome, definitely there's an increase in size of the ulnar nerve. So again, it can be involved due to the thrombosis of the ulnar artery, or any vein, thrombosis of the vein, which can get enlarged, or any neuroma formation, you can get the nerve being entrapped. Okay, see, you can see here that there is a neuroma. Okay, it could be a ganglion also, ganglion which is compressing the nerve, which is marked by the arrowheads. So coming to the last nerve, that is the radial nerve. Radial nerve has a very interesting course starting from at the arm. So it is crosses over from lateral, medial to lateral on the posterior aspect of the arm in close relation to the humerus bone. Okay, then finally it enters, it pierces the intermuscular septum at the lateral aspect of the arm, distal aspect, just above the elbow, and then it pierces it enters the substance of the brachioradialis, and then it comes into the anterior aspect of the arm, and another level at the lateral epicondyle level, it divides again into the sensory branch, that is the PIN. It gives off the PIN and the superficial sensory branch. The sensory branch continues all the way distally, and it is a part of the anatomical snuff box. And then you can appreciate, if you follow the nerve, it crosses over from the extensor compartment, that is the extensor compartment 1 to the second, onto to the second extensor compartment at the wrist. Okay. So as you can see that it has a lot of the extensor muscles of the forearm are completely supplied by the radial nerve. Okay. So these are the different cut sections, cross sections. This is at the posterior aspect of the arm, very close, in very close relation to the humerus. Okay, the mid shaft of the humerus, and then again it moves away from it. This is at the distal level. Okay, that's what we're talking about. So this is the compartment 1. Okay, so where is the nerve now? So at this level, the distal level, it is in close association with the cephalic vein. So if you see the causes, there are very unique causes, like even cephalic vein cannulation have been caused to cause any trauma to the nerve, right? And in the Colles fracture, the nail, the pins of the Colles fracture stabilization pins, they have, because it is closer to distal radius, so those pins have been one of the causes for the involvement of the sensory aspect of the sensory branch of the radial nerve. Okay, so yeah, this is the crossover what I was talking about. From the anatomical stuff marks over here, from the first, very superficially, it is crossing over to the second compartment, extensor compartment. So radial tunnel syndrome and PIN syndrome, these are the compressive neuropathy of the deep branch of the radial nerve at the region of the supinator muscle. Okay. So one thing I forgot to mention is, in the anatomy, if you see, it is closely in relation to the supinator muscle. Okay. The supinator muscle. So the proximal fibers over here, the proximal edge, that is nothing but the arcade of Froese. So this is one of the areas where it can get entrapped. Okay. So the causes could be space occupying lesions, prominent recurring radial vessels, facial band of the radial head, systemic diseases, rheumatoid arthritis, polyarthritis, chronic hypoperfusion, and post-systemic illness like angioneuropathy. So the clinical features can be painless palsy of the extensor muscles of the forearm. Okay, so that is if it is in the proximal level. Whereas at the distal level, if you see, it can mimic decoherence. It can, at the proximal level, it can mimic the lateral epicondylitis as well. Okay, so it may not be a painless palsy. There can be tenderness and pain at the lateral aspect of the proximal forearm, which can mimic the lateral epicondylitis. So the clinical features are very important. So in the PIN syndrome, is what we can see in an ultrasound is enlargement of the PIN at the proximal portion of the compression site. Again, a 15 mm square cutoff value of the PIN diameter is diagnostic criteria. Okay, it's 1.5 millimeters square. Sorry. So that will also show presence of hyperemia of the nerve on the Doppler image. So now again, it's not only the nerve, then the muscle. So ultrasound can also reveal echo difference of the dorsal extensor muscles because of denervation as compared to the contralateral side. So we always have to compare to the normal side. So coming to the last syndrome, that's a Wartenberg syndrome. That's entrapment of neuropathy of the superficial branch of the radial nerve at the level of the distal forearm and wrist. Okay. So the clinical features can be pain in that area, numbness and paresthesia in the radial side of the wrist and the thumb. So this is the one which can mimic decoherence tenosynovitis. So again, ultrasound can help you out there. The pain is the same side, you don't know what it could be. So toggle ultrasound, put your probe there and evaluate the tendons. Okay, evaluate the tendon and look for the nerve also. So what other features are you seeing over there? So that just helps to distinguish from Wartenberg syndrome, and also because the first MCP, right? So the trapezium metacarpal joint arthritis also could be one of the causes. So see how ultrasound is helping you to distinguish between so many causes and helps you to pinpoint the cause. So thus, high resolution ultrasound is a useful method of examinations for the evaluation of peripheral nerves, especially median, ulnar, and radial nerves of the upper extremity. However, the quality of ultrasound image may differ depending on the examiner's knowledge. The anatomic location, normal ultrasonic appearances of the peripheral nerve should be noted when the ultrasound is performed and should be always compared to the control side. Thank you for your patient hearing. These are my references.